Hello and welcome, everyone. Thank you for joining us on today's session on the Mental Health Services Act. My name is Angela Brand. My pronouns are she, her, and I'm with the CARE TA Center. The MHSA has a lot of information embedded within it. And so because of the complexity of the act, because of some of the nuanced pieces within the different components, this presentation today is really a high-level overview. We just want to provide a baseline understanding of MHSA so that as we move into some of our upcoming sessions that are more topical focused, we've been able to provide some foundational understanding that'll help support those future sessions. And so in addition to some of the information that we're providing today, we have sessions planned on housing, youth and foster care services, enhancing your full service partnerships or FSPs, as well as substance use disorder services. This is just a brief list of the acronyms that we have in our presentation today. And I am joined here by my co-presenter, Danny Offer. So I'll go ahead and give you a second to introduce yourself to the team, Danny.
My name is Danny Offer. I'm with NAMI, California, and I'm just looking at my profile picture here, realize I'm wearing the same outfit as I was in the picture. I always feel a little called out when that happens, but I assure you I do own 2 sports coats, in fact. But it's really nice to be with you all. I've been a legislative advocate for NAMI, California for about 4 years now. And in my time, I don't think I've ever met a single legislative advocate who said, I always wanted to be a legislative advocate. And I'm no different. I never wanted to be a legislative advocate, but NAMI was something that was really, really close to my heart. I am a family member of someone with a serious mental illness. And so I have spent about the last 25 years of my life working with my loved one, trying to get care for her, and all of the adventures that entails with a family. So NAMI was a real godsend for me when I first found out about them 10 years ago. So I feel really lucky to work with an organization like this. And frankly, really lucky to work with people like you. I imagine that working in county behavioral health can sometimes feel like a really thankless job. So let me just be one person to try to rectify that by saying thank you very much for doing what you do.
Real quickly, I'll turn it over to Danny. We're going to provide just a little bit of information on the MHSA, kind of how it came to be, what are some of the high-level components that folks need to keep in mind when we talk about the MHSA.
So Angela did warn you that we're starting at the baseline. So here we are at the baseline. What is the Mental Health Services Act, also known as the MHSA? It was a voter initiative passed in 2004. By Proposition 63. And this created a 1% tax on personal income in excess of $1 million to expand mental health services. So that's why you'll often hear it referred to as the millionaire tax. This was an unprecedented piece of legislation in California for a number of reasons. Its funding source, quantity, and allocation is dedicated for mental health services, including times of budget cuts to many other public programs. It was intended to engage communities in prioritizing which service elements would be funded, and it was focused on developing preventive and innovative programs to help transform the mental health care system in California. The MHSA provides funding, personnel, and other resources, best practices and innovative approaches, prevention, early intervention, treatment and recovery, and community partnerships and stakeholder engagement. I'm sure you all are familiar with the 5 components of MHSA, but just to go over it very quickly, first is community services and supports, also known as CSS. Second is prevention and early intervention, also known as PEI. Third is capital facilities and technological needs, CFTN. Then we have 4th, workforce education and training, or WET funds. And lastly, we have innovation. So what are the guiding principles of the MHSA, or the core values? Well, first, it's to be client-driven. So this means the client has the primary decision-making role in identifying their needs, their preferences, and strengths, as well as a shared decision-making role in determining the services and supports that are most effective and helpful for them. Client-driven programs or services use the client's input as the main factor for planning, policies, procedures, service delivery, evaluation, and the definition and determination of outcomes. The second guiding principle is that it's to be family-driven. Families of children and youth with serious emotional disturbances have a primary decision-making role in the care of their own children, including the identification of needs, preferences, strengths, and a shared decision-making role in determining the services and supports that would be most effective and helpful for their children. Family-driven programs use the input of families as the main factor for planning, policies, procedures, service delivery, evaluation, and the definition and determination of outcomes. Next, we have cultural competence. And this means incorporating and working into all aspects of policymaking, program design, administration, and service delivery to achieve equal access to services of equal quality, treatment interventions and effective outreach services, proper identification of strategies to reduce or eliminate disparities, an understanding of the diverse belief systems concerning mental illness, health, healing, and wellness, the understanding of historical bias, racism, and other forms of discrimination on racial or ethnic, cultural, and linguistic communities, including their mental health, the adoption of contractual services to address the needs and values, and strategies promoting equal opportunities. Next, we have community collaboration, which is a process by which clients or participants and/or their families receiving services, other community members, agencies, organizations, and businesses work together to share information and resources in order to fulfill a shared vision and goals. Next, we have integrated service experience, which means the client, and when appropriate, the client's family, accesses a full range of services provided by multiple agencies, programs, and funding sources in a comprehensive and coordinating manner. And lastly, we have focus on wellness, recovery, and resilience. Planning for services shall be consistent with the philosophy, principles, and practices of the recovery vision, which is to promote concepts key to the recovery for individuals who have mental illness, which is hope, personal empowerment, respect, social connections, self-responsibility and self-determination, and to promote client or participant-operated services to support recovery. So what are the goals of the MHSA? Well, the goals are to reduce the duration of untreated mental illness, reduce negative outcomes that may result from untreated mental illness, prevent mental illness from becoming severe and disabling, improve the timely access to mental health services for underserved individuals, reduce stigma and discrimination, increase the number of individuals receiving public mental health services, and to promote a recovery vision for individuals with mental illness. So who are the MHSA populations? Well, the MHSA is intended to increase access and services for underserved, unserved, and inappropriately served populations in the following age groups. First, we have children and youth, which is ages 0 to 15. Then we have TAY, or transition age youth, which is ages 16 to 25. Then we have adults ages 26 to 59, and older adults ages 60 and up. So this is just to show that the MHSA is guided by multiple rules, regulations, and codes. All of these can be accessed in the following places. So first we have the Mental Health Services Act itself. Then we have Welfare and Institutions Code, or WIC code. Then we have California Code of Regulations. And then we have information notices that DHCS releases on occasion. So I love this tree. The Legislative Analyst's Office was nice enough to put this together a few years ago. So the dollar amounts are a little bit outdated, but I feel like it just gives a good picture of the entire tree of public behavioral health funding. Gives you an idea of the percentages. So while the presentation is on MHSA specifically, we feel like it's helpful to know how it fits into the larger structure of California's mental health funding tree. So first, let's go to realignment. This was the transfer of administrative and financial control from the state to counties. And it's unique to California and plays a critical role in the state's mental health financing. California underwent two major realignments, one in 1991 and then one in 2011 that affected mental health program responsibilities. The 91 and 2011 realignment funds typically are viewed as distinct revenue sources because they were authorized under different statutes and fund different obligations. Realignment funding starts with a base allocation to counties that is an estimate of the amount the state would have spent on the various programs that were transferred to the counties. Then the state collects dedicated revenue, which is sales tax and vehicle license fees, which is then distributed monthly by the state controller's office until each county receives a total amount of funds equal to the previous year's total. Leftover dedicated revenue funds are placed into separate designated growth accounts. And then at the end of the year, these growth accounts are distributed to county programs based on formulas set in statute. Then we have the MHSA. And then we have the State General Fund. Then we get to federal funds or Medi-Cal funds. And these are funds received by California for public mental health care and are used to reimburse the state and counties for services provided to Medi-Cal beneficiaries. Federal payments match state spending based on the federal Medicaid assistance percentage, which in California is set at 50% for most expenditures. And because Medi-Cal is a federal entitlement program, it has a legal obligation to pay for all medically necessary covered services for eligible individuals. And lastly, we have SAMHSA block grant funds. So the Substance Abuse and Mental Health Services Administration, also known as SAMHSA, block grants are an additional source of federal mental health funding in California. This block grant funding is awarded by the state to counties based on a legislative formula and application process. And while these block grants make up a small percentage of the total public mental health budget, the SAMHSA grants are a flexible funding source for services for adults and children who are ineligible for Medi-Cal and with no other health coverage. So what's the MHSA funding structure? So first we have the allocations. Taxes are collected by the state treasury, and MHSA funds are distributed by the state controller's office on a monthly basis to counties. And individual county allocation percentages are based on the estimated need for services, self-sufficiency in resources, and small county minimum allocations. Then we have the local MHSA fund. Each county is required to have a local mental health services fund that is just to be used for MHSA expenditures. Then we have expenditures. So as you probably know, all counties have to develop a 3-year program and expenditure plan, which includes estimated funding by component, estimated expenditures by component, and then the county has to gain approval of the plan through an annual stakeholder process. All MHSA expenditures are required to be in accordance with an approved plan, and they cannot be used to supplant existing resources. Then we get to reversion. So WIC code specifies that funds must be spent within a certain time period, or they have to be returned to the state. So CSS and PEI must be spent within 3 or 5 years, depending on your county population. So 200,000 population is a threshold there. So if you're a large county, above 200,000, then you get 3 years. If you're a smaller county under 200,000, it's 5. Innovation funds must be encumbered within 3 or 5 years, and then they're safe from reversion for the life of that approved innovation plan. And then WET and CFTN must be spent within 10 years. Funds dedicated to the prudent reserve are exempt from reversion. And the reversion period starts at the beginning of the fiscal year in which the funds are available. So just a few considerations. As you likely know, MHSA funds are very volatile. The majority of funding is driven by economic conditions, and it's not based on needs or services. Essentially, when rich people are doing well, the MHSA does well. And when the opposite is true, the MHSA declines. Then there are restrictions and limitations. Funds cannot be used to supplant existing state or county funds for mental health services, and funds cannot be used to pay for services in long-term hospital or institutional settings. MHSA plans have to go through an approval process through the Board of Supervisors, and all expenditures must be consistent with an approved MHSA plan. And as we touched on earlier, funds must be spent within a specified time frame.
All counties that receive MHSA funding have to develop a 3-year program plan as well as an annual update. Both of these plans and updates are to be developed with community stakeholders through a process known as the Community Program Planning Process, or the CPP. These plans and the update provide information on the projected revenues, how that money will be spent, and then the updates provide information on how that money was spent. They go through the following review process that's listed on the slide. A draft is developed through the community program planning process with community stakeholders, and that includes consumers, family members, parents, caregivers, youth, older adults, folks from unserved and underserved communities, hard to reach populations that represent the demographics of that county. And we'll get into the CPP here in just a minute. That draft is then circulated during a 30-day public comment period. And then the local mental health board will host a public hearing on that draft to provide recommendations and proposed revisions. The county will then adopt the plan and update, and the Board of Supervisors will approve the final plan. Again, the community planning process is a huge component of the MHSA. There's a lot of conversation about what it is, what it should be, what it has been, what it could be. And we're not going to get too into that today. As I did mention earlier, we're planning for a full day convening on the community planning process that'll go over some of these rules and requirements, as well as strategies for community engagement, working with local CBOs, and providing some tools for counties around the different ways that the CPP can be done and the way to work within communities. And so, again, just a high-level overview. The community planning process is a very dynamic process. It needs to include folks from the community that are impacted by the system. So that includes the stakeholders that you see listed there, adults, older adults, family members, transition age youth. But stakeholders also include service providers, law enforcement, folks from education and social services, representatives of underserved communities, hard to reach populations, folks that are representative of the diverse demographics of the county, and even folks, mental health boards, local behavioral health directors, boards of supervisors. Everyone that plays a role in the system should have a seat at the table. Again, recognizing that there's different feelings about the experiences that folks have had with their local community program planning process. We're not going to get into that here today, but just recognizing that there's a lot of opportunity to explore how we can all work together to build the capacity of folks to do this well in a representative manner. And so as we're thinking about planning out for a CPP session, what are some of the things or some of the information that would be most helpful to you? Recognizing that we have varying experiences and perspectives in the room today. As a stakeholder, as someone working for a local county behavioral health department, what are some of the tools and supports that you find you would need in your role working in the county? Are there things that you would love to know more about? Like I said in the beginning, we've been working closely with the counties in terms of developing the content for these learning opportunities. And in that, learned that there's a spectrum of experience for folks working at the county level. We have a lot of folks that are new to their role and learning more about how to do this. And so how do we equip you with those tools and supports? Alternatively, for those that have been in their role for a long time, we're probably going to come knocking at your door to help us share out some of the wisdom of the work that you've done. But knowing that we're always in a learning role, there's questions and things that I think we want to be responsive to across the board. So anything that you'd like to share on that, definitely please do. We want to be as responsive to your needs as we can as we develop these learning opportunities. Full disclosure, this is at a very high level. But we are going to touch on what all of the components are and a little bit about each one, including the funding allocation, any populations of focus or carve outs in that funding that are notable. And so I will pass it to you, Danny, for the first part.
Okay, so the MHSA components are the 5 pots of funding. So first we have community services and supports, which is CSS. And this is outreach and direct services for children, adults, and older adults with the most serious mental health needs. Next, we have prevention and early intervention, or PEI. And these are prevention services to promote wellness and prevent the development of mental health issues, and early intervention services to screen and intervene in early signs of mental health issues or a mental illness. Then we have capital facilities and technological needs. This is infrastructure development to support the implementation of the technological infrastructure and appropriate facilities to provide mental health services. Then we have workforce education and training, or WET funds. And these are used to support, to build, retain, and train the public mental health workforce. And lastly, we have innovation funds. And these are for new approaches that may improve access, collaboration, and or service outcomes for all mental health consumers, with a focus on unserved, underserved, and inappropriately served populations. Community supports services and supports provide all the necessary mental health services to seriously mentally ill children, adults, and seniors for whom services under any other public or private insurance or other mental health or entitlement program is inadequate or unavailable. Many CSS services are also eligible to bill to Medi-Cal. And MHSA funds can also be used for non-Medi-Cal eligible expenses, such as non-mental health services. So the CSS populations of focus. CSS covers services and supports for populations across the lifespan, including children, adults, and older adults. And this includes a focus on individuals or families with situational characteristics, such as children and youth with involvement in the foster care system, juvenile justice, or probation. Individuals or families who experience homelessness or are currently at risk of homelessness. Those who have had frequent or recent involvement with the criminal justice system. Those who may have a history of hospitalization, including those transitioning out of an IMD or a state hospital. Frequent users of hospitals or emergency services. Those who have a presence of a co-occurring substance abuse, developmental, or medical issue, or those who are at serious risk of suicide. So the CSS component offers a range of services that include traditional mental health services, peer support, respite, housing and residential services, counseling, assessments, crisis continuum services, employment and education, all developed through the lens of recovery and wellness. The CSS component has the following service categories. First, we have full service partnerships, or FSPs. FSP includes a whatever it takes commitment toward progress on defined behavioral health goals. This plan can include traditional mental health services, as well as a wide array of other services like housing, employment services, peer support services, substance abuse treatment services, recreational or other therapeutic services that are consistent with a commitment to support and do whatever it takes to help the person progress toward recovery and wellness. These programs can provide the range of services required by clients directly, or can link them to other organizations and providers to ensure that the services agreed to in the plan are available to the person and the family where appropriate. And then we have general system development. GSD is for the expansion or enhancement of the public mental health services to increase the number of people served. It may be used for treatment, including alternative and culturally specific treatments, such as peer support, supportive services to assist with employment, housing, and/or education, wellness centers, case management, needs assessment, crisis intervention or stabilization, family education, and strategies for reducing ethnic or racial disparities. And lastly, we have outreach and engagement. And these fund activities to reach, identify, and engage underserved individuals and communities in the mental health system to increase access and reduce disparities. Outreach and engagement funds may be used to pay for strategies to reduce ethnic or racial disparities, food, clothing, and shelter, but only when the purpose is to engage unserved individuals and, when appropriate, their families and the mental health system, as well as general outreach activities to entities and individuals. So a few considerations on housing. Housing is a complex issue that requires extensive community collaborations and partnership. The MHSA is a flexible funding source that may be used in various ways to support those who are experiencing or at risk of homelessness. Housing supports must be outlined in the 3-year program and annual expenditure plans, and may include various support components such as rent subsidies, security deposits, utility supports, housing vouchers, short-term, transitional, and temporary and permanent supportive housing, as well as mental health treatment and crisis services. Now we move on to prevention and early intervention, or PEI.
I just wanted to jump in real quick. We will be diving into housing in our next session. And so we are at PEI, prevention and early intervention, designed really to prevent mental illness and serious emotional disturbance from becoming severe, disabling, and costly to individuals, families, communities, and the state. When we look at that, the funding allocation, so total percent of the revenue is 19%. This is one of the areas where there's a carve out again. So at least 51% of PEI funds must be used to serve individuals aged 25 or younger. When folks talk about PEI, a lot of times you'll hear them refer to what's called the 7 negative outcomes. PEI services are designed to address to develop programs, strategies, ideas, things that can address the larger system. So the outcome is to avoid prolonged suffering for individuals, school failure or dropout for young people, homelessness, suicide, incarceration, or involvement with the criminal justice system, unemployment, or removal of children from their homes. There's a lot of conversation about PEI, how it can be spent. I know that some of you are involved in some current conversations that are taking place with the Mental Health Services Oversight and Accountability Commission on their current process to identify priorities for PEI funding. But generally, PEI funding is to what it says, to get in early, to address those folks that may need supports and services at the very onset, to get in when there are symptoms that are starting to show, so that the outcome is, more positive for that individual or their family. And so the development of programs and supports for individuals across the lifespan, again, PEI is for individuals across the lifespan, including that component for 51% to be spent for children or individuals age 25 and younger, but a priority focus on the following populations. So underserved cultural populations, individuals experiencing onset of serious psychiatric illness, children and youth in stressed families, trauma-exposed individuals, children or youth at risk for school failure, and children or youth at risk of experienced juvenile justice involvement. And so thinking about considerations for PEI program funding, it's not able to be used to sort of fill in the gaps. So that if there's already existing programs for consumers and individuals, children, family members, consumers, it's not really a fill in the gap kind of thing. It's to work at the beginning of the system. Sometimes folks will, you'll hear we've got the 80-20. So right now we've got about 20% of funding going to PEI, 80% going to community supports and services. And the conversation sometimes goes toward, well, if we put more money into prevention, we won't need to spend so much money downstream. And that's always been a conversation in California. Again, this is high level overview of what the MHSA is. I'm not going to get into where we're at after all the years, but PEI is really to be at the forefront. It's that upstream idea that if we can get in here, we can start to identify ways to reach children and individuals and young people, work with their families to get them into services and supports earlier so that we can mitigate the consequences down the line, those 7 negative outcomes. Again, PEI, capital technology projects, building, housing, things like that. Workforce education and training is not part of the PEI component. That's its own component that we'll cover here in just a moment. And it says here large scale projects such as social marketing campaigns and training curriculum. A lot of PEI is around outreach, educating individuals, families, educators, folks working in schools, general community members about what mental health and mental illness is and is not. Folks often won't seek services out of fear. We talk a lot about stigma and stigma reduction. And some of those social media campaigns like the Each Mind Matters, which is now Mental Health for All. Those are state level, state run programs that is funded at the state level around PEI. And so a lot of those types of activities aren't able to be funded through PEI. So innovation, I think this one is mine too. So innovation is about 5% of revenue. Innovation is kind of let's try it out and see what we can do. It's a smaller funding stream that counties can tap into. It's really designed to learn and to develop things that are outside of evidence-based practices. There are ways to explore community-defined practices or promising practices, best practices, things that are emerging in the behavioral health space. And the primary purpose of those projects is to increase access to underserved or unserved groups, hard to reach populations, folks that maybe don't engage with the behavioral health system, increasing the quality of mental health services, promotion of interagency and community collaboration, really to increase access to services overall. The innovation component, a lot of stakeholders, a lot of community members will talk about innovation being a really great avenue for engaging with diverse communities, because you can try different strategies to getting folks into services in a way that doesn't really feel like a medical model of care. Providing behavioral health services that aren't just going to a clinic and talking to a doctor or getting medication. It's a lot of what might work well for this particular population. One of the challenges sometimes that folks will talk about with innovation, and it might actually be on the next slide. We'll go to the next slide. The regulations require that innovation projects have to introduce a new practice or approach. The challenge there sometimes is we may run out of ideas, or folks may feel like we're running out of ideas. And so how do we adapt programs and different strategies that are taking place? And so there's a caveat that you can make a change to an existing practice, but apply it in a different way or to a different population. Working to apply a community-driven practice or approach that has been successful in a non-mental health or non-behavioral health setting. Again, because this is a high-level overview, there's some pieces of these components where we can really take a deeper dive and explore what counties have been able to do through these components, some of the things that they've learned, especially around innovation. It's a really fascinating component of the structure. A lot of programs have emerged in so many different ways that don't lend to kind of that traditional medical model. And so we'll ask again in just a couple minutes if folks are interested in learning more about that. But the innovation component it's a really dynamic component. It offers a lot of creativity and opportunity for the county to kind of work outside the box in terms of how to reach folks and how to provide services and supports to them in a non-traditional way. So again, just some considerations. Innovative projects can be used for a number of different things. So education and training, advocacy, research services. It can support administrative functions. It can't be used to implement an approach that has already been done before. Again, kind of goes back to what I said, where being really careful about, finding a new idea. It can't cover any sort of longitudinal studies or any sort of ongoing programs that would be more appropriately suited for the CSS or PEI components. And addressing an unmet need is not alone sufficient to receive funding under this component. So again, if there's interest and we start to dive in more on these components, we can kind of unpack some of these considerations.
So WET funds are workforce education and training. WET programs are designed to increase and sustain the number of qualified individuals, including clients and family members, who are working in the public behavioral health system. And funds are meant to increase mental health career development opportunities and include supports for both prospective and current public mental health system employees, contractors, and volunteers. These training components include mental health career pathways, which are educational, training, and counseling programs designed to recruit and prepare people for entry into a career in the public mental health system. Then we have residency and internship programs. These are funding for psychiatric residency programs, internship programs leading to licensure and physician assistant programs with a mental health specialty. These are designed to address workforce shortages and supplement existing programs to increase the share of licensed professionals practicing in the community public mental health system. Then we have training and technical assistance. This is a very broad funding category that's defined as events and activities in which individuals and/or organizations are paid with MHSA funds to assist all individuals who provide or support the public mental health system in better delivering services consistent with the fundamental principles intended by the Act. And then we have the financial incentive programs. And these can be scholarships, stipends, and loan assumption programs. And lastly, we have workforce staffing support. And this is the specific earmarking of funds to plan for, administer, support, or evaluate the workforce programs and training included in the other WET categories. So a few considerations. WET funds may not be used for the workforce recruitment and retention needs of systems other than the public mental health system, meaning such as criminal justice, social services, and other non-mental health systems. They can't be used for direct service provision. WET funds cannot be used for offset lost revenues that would have been generated by staff who participate in WET programs. And lastly, they cannot be used for personnel, operating, and administrative costs. The capital facilities and technological needs component emphasizes providing the capital facilities and technology to enhance counties' ability to provide the community-based services and increase access to services that are culturally and linguistically appropriate. And it has two components. First, the capital facilities. And these are funds to acquire and develop land and/or construct or renovate buildings in which MHSA administrative activities, services, and/or supports are provided. And this can include acquiring a building or land that will be county-owned, or construction or renovation of buildings that will be county-owned. And second, we have the technological needs portion of it. And this means uses and/or strategies of community-based facilities which support integrated service experiences that are culturally and linguistically appropriate. This can include electronic health record or personal health record system projects, data warehousing projects, or clinical data management. Note that these funds cannot be used to pay for housing.
So here we'll move into some state level considerations. Just from a historical context, helpful for folks to know that the department, California used to have a Department of Mental Health. It closed in 2012. And it shifted a lot of the responsibilities for the Mental Health Services Act and the public behavioral health system across various agencies. Sometimes folks kind of refer to it as when the band broke up. Other folks refer to it as, oh, my dog feels strongly about this section. Some folks will talk about, kind of the custodial jurisdiction of the behavioral health system. And so there are quite a few agencies that do get some Mental Health Services Act funding, including the Veterans Affairs, the Department of Education. We won't go into all of those. We are just providing some information on kind of the three that handle a majority of the roles and responsibilities.
So one of the big state partners involved in MHSA, of course, is the Department of Healthcare Services. And DHCS is primarily responsible for overseeing the use of MHSA revenue and expenditures. So they review the MHSA allocation methodology and monitor distribution and reporting of MHSA funds. They calculate and manage the amount of mental health service funds that are subject to reversion. They develop and review county revenue and expenditure reports. And they develop the regulations for the community services and supports, WET funds, and capital facilities and technological needs components. Angela, I believe this is you.
So the next is the MHSOAC, or the Mental Health Services Oversight and Accountability Commission. Their primary function is to oversee the implementation of the MHSA. And if you look at some of their roles and responsibilities, the commission does quite a lot. They advise the governor and legislature on mental health policy. They are the agency that, excuse me, has been responsible for the development and maintenance of the regulations for the PEI and innovation components. They do approval of all county innovation plans. They also do plan review. They have a team that reviews each county's mental health service plan. And then they also have oversight of quite a few funding streams. And so SB 82 triage, which is expanding this year and the year before, they've been getting more money in. First Mental Health Wellness Act is what they're referring to as now. And they have some components for schools, youth, and peers. They also oversee the Student Mental Health Services Act funding, as well as stakeholder advocacy grant funds. And so the commission has expanded their role quite a bit over the years. Again, this session is not really to dive into what the agencies do or should do or not do, or where there's opportunities for folks to do more. It's really just to sort of establish the understanding that it's a little bit fragmented at the state. And so, you have different folks that kind of oversee different pieces. And so just kind of knowing who to go to for questions and which agency oversees which piece is where we were coming at from that. So we'll move to the next slide. That I think is back to you, Danny.
This was a big one. As some of you know, a few years ago, the state changed its name from the Office of Statewide Health Planning and Development to the Department of Healthcare Access and Information. And this was great news for me because as a lobbyist, there are few humiliations greater than mispronouncing Oshped or Oshpod. I could never get which one it was. So I'm very glad to have a straightforward HCI. And they're responsible for the MHSA 5-year workforce and education training plan, psychiatric residency programs, and they serve as the statewide technical assistance center. They also oversee residency programs for physician assistants in mental health, as well as the mental health loan assumption program.
And again, this section provides a brief overview on some of the legislative changes that have impacted the Mental Health Services Act over the years. A lot of them are just for reference. As Danny was talking about earlier with the financing, some of those legislative impacts came down to or impacted the budget. Some of those have been around reversion or how counties can use certain components of their funding. And so the ones that we have listed here, it's just high level overview, especially for those of you that are new to your role. You may hear folks refer to AB 100 and it's, well, what is that and how does that fit into this? And so this just provides kind of that high level overview, and I'm going to send that back to Danny because that's definitely your area of expertise.
And yeah, just to build on that a little bit, one of the reasons I feel like this is helpful, at least in practical terms, is, sometimes Google is your best friend when you're trying to research things, and then other times you realize that you're looking at a document that may be a bit outdated. So I feel like these bills at least highlight that things have changed a bit over time. So just something to be mindful of when searching out various documents that may be outdated. So just briefly, AB 100 was one of the big ones. It eliminated the annual plan review by DMH and the OAC, and it also shifted distribution of MHSA funds to go to the counties directly on a monthly basis. And then we have AB 1467, which transferred the remaining state MHSA functions from former DMH to DHCS, and then further clarify the roles of the OAC and DHCS. And then we have AB 114, which dealt with the reversion of MHSA funds. And then there's AB 192, which clarified that a county's prudent reserve for their local mental health services fund shall not exceed 33% of the average CSS revenue received in the local MHSF in the previous 5 years. Also, it established a reversion account. And then there's SB 79, and this amended the MHSA by not reverting innovation funds to the state as long as the innovation funds are identified in the plan for innovative programs that has been approved by the OAC. AB 81 came under COVID, and that just had some COVID-related flexibilities and extensions to the MHSA. AB 638 allowed for the use of PEI funds to support SUD services. And AB 638 was chaptered into law to allow PEI-funded services and activities to be used to broaden the provision of community-based health services to include strategies that include substance misuse or SUDs and needs relating to co-occurring mental health and substance use services. This became effective just last January of 2022. I think we now have another poll.
We do. So thinking about kind of the changes over time, would it be helpful if we had a follow-up session on legislative and policy impacts, where we could crosswalk some of these policies, which are the components they touch, and kind of what that means for you all in the day-to-day of the work that you do. And you can access all of our information, our resources, any of our previous learning events are all on our website, which is just how to stay in touch with us. So you can go to our website. We are on social media, and you can join our newsletter sign up. Thank you very much, everyone.